بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, dear colleagues, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this very special evening where we are resuming our activities in the IMC Family Medicine Club. And we are witnessing today another edition of the club, which is a 38 scientific sessions, and this is in collaboration with the Saudi Society for Family and Community Medicine and a sponsorship with GSK. So I would like to welcome you here, and I'm sure that we are going to have a very nice interactive session where we're going to learn a lot of knowledge and we'll exchange expertise in very important topic that we are going to highlight today. But before we start, I would like to set up the stage by saying that Alexander Fleming, in 1928, when he discovered that the fungus Penicillium kills the bacteria, he did a dramatic change in the landscape of saving lives. So with this kind of invention and discovery, he saved lives of people across the nation where many people are dying in thousands and millions because of infectious disease. And since then, the life expectancy of the human being has been increased dramatically in the past 100 years. And to tell you more, which is very important to see the impact of this discovery, now the life expectancy has been increased from 28% to 80% in the management of pneumonia. So pneumonia is not anymore a disease that kills people because we have a strong weapons and we have a strong guns of antibiotics. But the problem, ladies and gentlemen, is that nowadays we are witnessing an emergence of microbial resistance. And this is in fact because of overuse of antibiotics, misuse of antibiotics, and antibiotics which is used in the hospital generated a special group of microbes that is resistant, and also the prophylaxis of medications. And unfortunately, ladies and gentlemen, when I talk about primary care, it has been identified that the most prescriptions of antibiotics takes place in the primary care setup. So today, we are going to highlight the use of antibiotics and the guidelines of the antibiotic use in primary health care. So I would like to say the statement, the more we use them, the more we lose them. So we have to use them meticulously in order to save the life and to be very meticulously selecting the antibiotics that safeguard our patients in our family medicine practice. So ladies and gentlemen, I would like to welcome you here in this session where we are going to talk about antibiotics. And we have been privileged today to have two of the prominent speakers, Dr. Badr bin Hamd and Dr. Wa'il Abdel Kafi. Both of them, they are going to enrich our gathering today with two important topics. One is about how to approach patients with upper respiratory tract or respiratory tract infection in primary care and what are the modalities of using the antibiotics. And the other topic will be the spotlight on community-acquired respiratory tract infections and the antimicrobial resistant. So I would like to welcome you here. You are attending physically, and we have been also joined by 1,000 of online attendees. So I would like to thank them for being with us here today. So I would like to remind you to prepare your questions. So at the end of the sessions, we'll be having a Q&A session. And I would like to urge our colleagues who are attending virtually to put their questions in the Q&A box so we'll be able to forward it to the speakers. So I would like to mention that this CME hours is accredited by the Saudi Commission for Health Specialty for 4 hours. So all of you will be eligible to have it. And I would like to introduce our first speaker, Dr. Badr bin Hamd. He's well-known consultant family medicine, and he's the chairman of the family medicine department in the International Medical Center. He has been contributing in a lot of activities, and he holds a certification of continuous medical educations, a lot of contributions for developing the capacity and the competency of our family physicians who are in the residency program in family medicine in the International Medical Center. So Dr. Badr will talk about the approach to the patient with upper respiratory tract infection. So I would like on your behalf to welcome Dr. Badr. So thank you for accepting invitations and being part of our scientific session.
Okay, thank you, Dr. Ashraf. Assalamu alaikum jami'an. Good evening, everyone. I hope my voice is clear. So thank you, first of all, thank you, Dr. Ashraf, for your introduction. Thank you, Dr. Ashraf, for your introduction. Complex testing by hands to organize humanity and DSK for organizing this scientific meeting. Okay, so talking about upper respiratory tract infection is not an easy topic, it's a huge topic. That's why we have multiple, if we want to talk about upper respiratory tract infection, so we can talk about multiple of the diseases that we are facing on a daily basis in our clinic. So I thought we can make it so we include rhinitis, sinusitis. So I would like to always use the terminology rhinosinusitis, common cold, pharyngitis, tonsillitis, epiglottitis, laryngitis, laryngotracheitis, tracheitis. So we have many terminology and many diseases that we are dealing with in primary care. So what about the causes of upper respiratory tract infection? So the causes that we know is mostly viral or bacteria, or sometimes, and this is not frequently seen, which is fungal infection. So how are upper respiratory infection diagnosed? In primary care setting, so the only thing, or the main thing, is using our clinical judgment, history, examination. So ENT examination is very important, followed by, in some cases, like nasal swab plus minus culture. So we have this luxury in hospital days. In primary care, we don't have it. So we have the COVID swab, we have the influenza A and B swab. So you can use it wisely with certain patients. And then after that, we have throat swab, so we can use it in vague cases, okay, plus minus culture. CT scan for the paranasal sinus, we'll see the indication together and we'll discuss it together. When should we order CT scan? Can we order it as a family physician? Yes, we can order it. And finally, X-ray in general, X-ray and lateral radiograph for the epiglottis, or even chest X-ray for certain patients. So what are the symptoms of our upper respiratory tract infection? We have 12 symptoms for all upper respiratory tract infection, starting from cough, red eye, headache, myalgia, runny nose, fever, sore throat, joint pain, name it. So we have 12 symptoms. Sometimes the patient will come with one or with two. The challenge in family medicine is that we are facing patients in early presentation. So most of the time, our patient presenting to us with myalgia only, with only joint pain, or sometimes they are just feeling fatigue. Please do ENT examination. Most of the time you will find your patient is having nasal congestion, sinus pain, sore throat, so this is viral infection. So the question, how long do upper respiratory tract infection last? 10 years back, more or less, I used to tell my patient it is almost 3 to 5 days. Nowadays, I'm telling my patient 5 days, more or less, up to 10 days, and sometimes up to 2 weeks, and that's what we are seeing in our clinic. So because the topic is huge, I decided today to talk mostly about acute sinusitis or acute rhinosinusitis. So definitions are very important. So we'll talk today about many definitions because these definitions will guide our management. So acute rhinosinusitis is defined as symptomatic inflammation of the nasal cavity and paranasal sinuses lasting less than 4 weeks. The term rhinosinusitis is preferred because sinusitis is only inflammation of the sinuses, and most of the cases will include the nasal cavity as well. So what about classification? We have two types of classification for sinusitis. The first one based on the duration. So we are talking here about acute, less than 4 weeks, subacute from 4 to 12 weeks, Chronic, we are talking about persistent, greater than 12 weeks, and recurrence, acute rhinosinusitis, 4 or more episodes per year. What about the classification based on the etiology? So we have the viral infection, we have uncomplicated bacterial and complicated bacterial, and we will discuss what we mean by complicated bacterial infection. So, is it common in our practice, in ENT practice, pulmo, in family medicine, primary care, GPs? Yes, it's very common. Yeah, I can say I'm seeing almost like 5 patients more or less per week with having sinusitis ranging from mild to moderate. Rarely we are seeing severe patients. So these are the risk factors. So mostly older age, smoking, air travel exposure to some chemicals, dental disease, immunodeficiency, and gastroesophageal reflux disease can cause sinusitis. Of course, some of these can cause non-infectious sinusitis. So what about the symptoms of sinusitis? So we have most of the patients will present sometimes with sinus pain, sometimes with a typical presentation like dental pain, fatigue, dizziness. All of these are uncommon or atypical presentation for sinusitis. In severe cases, the patient could present with severe facial pain, with anterior, posterior, purulent discharge, and fever. So how to diagnose acute sinusitis clinically in the clinic? History, yes, you need to take thorough history with from your patient, and then after that you need to do a full ENT examination. So patients are diagnosed with either viral or bacterial based on the quality, duration, and progression of the symptoms. So what to examine in the clinic? In primary care, what do we have? What instrument we have? Otoscope? We don't have the scope like the ENT, so it's very easy. So it's easy to examine. Please examine the throat, examine the nose, examine the ear, okay? Simply just press on the sinuses. All of these will guide your clinical judgment about the case. And please don't forget to examine the nose, and don't forget to examine the ears, especially if the patient is complaining of ear pain. What about differential diagnosis? So in my life, I'm practicing family medicine more than 15 years now, so I didn't see, alhamdulillah, any case invasive fungal rhinosinusitis. Maybe our colleague will talk about it today. So second, and this patient, the majority of those patients mostly are immunocompromised, so please take care and pay attention for any patient coming with severe rhinosinusitis and immunocompromised at the same time. The second differential diagnosis is common cold, where there is no facial pain and the patient is complaining mostly about fever and sore throats. What about another interesting differential diagnosis? So one of the challenging differential diagnoses, which is migraine, very difficult to diagnose a patient with migraine and to differentiate sinusitis from migraine. You need to see the patient maybe in the follow-up. Sometimes we need to do the CT scan. Sometimes we need to re-examine the patient. Sometimes we need to refer the patient, okay? So it's one of the challenging cases to differentiate between migraine or cluster headache and sinusitis. Again, the same thing, dental pain sometimes. And I saw some patient coming to my clinic with just dental pain, and they ended having sinusitis. Of course, there are multiple different conditions that may cause facial pain, including neuralgia, TMJ, which is a common disorder in not only primary care, not only in family medicine, but in most of the clinic. But in my opinion, it is underdiagnosed until now. We need to just ask the patient more and more and follow our patient closely. Of course, allergic rhinitis, merely the patient will complain of rhinorrhea and sneezing. What other serious differential diagnosis? I saw this patient two weeks back. She was complaining of chronic facial pain, seen by different physicians, different specialty. All the diagnosis is acute rhinosinusitis. She's not responding. CT scan done, revealing nothing, but she's still feeling the pain. Finally, they decide to take a swab or to take a biopsy. She refused. She traveled, but they were vague. It was vague. So no one was brave enough to take the biopsy from this lady, and she decided to travel. So finally, they discovered that she is having sinus cancer. This is the first time I saw it in my life. So please consider this. But of course, it's rare, but you need to consider it. So what about acute bacterial rhinosinusitis, how to differentiate between bacterial and viral. So we have 4 main criteria, very easy to remember, very easy to practice. So if the symptom persists more than 7 to 10 days, usually in my practice, I wait for 10 days. Okay, symptoms initially improve, but then worsening, so we call this double worsening. Severe symptoms from the beginning, or it starts with simple common cold, then converted to sinusitis. We call this double sickness. So I like to start with this before talking about the management, because in primary care, as a family physician from the beginning, when should I refer the case to our colleague at the ENT, or even to neurology, or even to ER sometimes? So if the patient present with high persistent fever, not responding to treatment, periorbital edema or infection, cranial nerve pulses, abnormal extraocular movement, proptosis, vision change with all the symptoms of sinusitis, severe headache, altered mental status, meningeal sign, please, okay, don't follow up this patient, just refer the patient immediately to the appropriate specialty. So talking about this, what are the complications of acute bacterial sinusitis that we should know as a family physician, just to differentiate, and to pick up the case and directly from the first visit and refer to the appropriate specialty. So what we can see here, what is this picture? Anyone? The first one here. So periorbital. So this is periorbital cellulitis, and this is more severe orbital cellulitis. What is the difference? Why am I presenting that? As a family physician, I can deal with this. As a family physician, I need to refer this immediately. So this is the main difference. Once you ask your patient and examine your patient, if there is pain with eye movement, proptosis, ophthalmoplegia, diplopia, vision impairment, chemosis, and fever, so please, the probability of orbital cellulitis is higher, and please refer this case to emergency. So what other complication quickly? So osteomyelitis of the sinus bone, meningitis, intracranial abscess. So in these cases, the headache tend not to be relieved by over-the-counter medication. The patient would have neck stiffness, fever, and change in mental status, septic, cavernous sinus thrombosis. I didn't see this in my life, but we need to know about it. So usually the history, many patients with acute bacterial sinusitis have self-limiting disease. This is the first message. Acute bacterial sinusitis is a self-limiting disease for most of our patients. Patients rarely develop complications. I didn't see it in my life in the last 15 years, maybe in primary care. Patients treated with antibiotic may have a shorter course of illness. However, they also experience more side effects. So please choose and select the antibiotic wisely for your patient. So another question for you as a family physician, as a practitioner, observation or treatment? For whom and for how long? So observation is recommended for 7 days period. This is the newly update, okay? After diagnosis and symptoms plus symptomatic management. This approach for immunocompetent patient who have good follow-up. If you ensure that your patient will follow up and he's immunocompetent, you can give him 7 days, up to 10 days, no problem with that. So what about the symptomatic management? Please remember the 10 symptomatic management. Should we practice or should we prescribe all of these symptomatic management? No. You need to select some of this symptomatic management wisely according to your clinical judgment and according to the patient's symptoms. So we have 4 antihistamine, anti-inflammatory, anti-gastric reflux, antitussive, and we have 4 intranasal. We have intranasal saline, intranasal glucocorticoid, intranasal anticholinergic spray, intranasal decongestant. Should we use it in my life, in my practice? Maybe I use 4 or 3 of this. So it depends on your clinical judgment. So when to start antibiotic? When to start antibiotic for acute bacterial sinusitis? For patients who do not have a good follow-up, start antibiotic therapy at the time of diagnosis. Also start antibiotics for patients with clinical diagnosis whose symptoms worse or fail to improve, of course, 7 days or more. What about the older approach, which is from 2012? Still, I merged both together, and this is according to your clinical judgment. Still, if the patient having persistent symptoms more than 10 days, onset that worsening, and sinusitis with worsening symptoms or sign for 3 to 4 days, viral upper respiratory tract infection that lasted 5 to 6 days and were initially improved, then become worse. All of these criteria that help you as a physician just to start antibiotic for selected patients. So the message here, you can provide an option to continue observation for some patients. Not every single patient with acute, with proving with 100% criteria for acute bacterial sinusitis need antibiotic. So acute bacterial sinusitis may be self-limited disease and patient may improve without antibiotic therapy. So what do you think about this? Do you agree about this or not? This is my opinion. So do you agree? How many of you agree about this? Raise your hand, please. So acute bacterial sinusitis may be a self-limited disease and the patient may improve without antibiotics. Do you believe in that? Yes or no? Excellent. So I will just go fast here. So in many systematic review and meta-analysis that have found many patients with clinically diagnosed with acute bacterial infection improve without antibiotic therapy within 2 weeks. So we are talking here about immunocompetent patient with good follow-up. So what about the empiric antibiotic for immunocompetent patients? So the most important question, if you want to start antibiotic for acute bacterial rhinosinusitis, you need to ask these 2 questions for your patient. Is there any allergy to penicillin? Is there any risk factor for pneumococcal resistance? Okay, if you answer these 2 questions, of course, here you can find the criteria for high risk for pneumococcal resistance. Okay, if you, after answering these 2 questions, you can select your antibiotic easily. So for those with no penicillin allergy and no pneumococcal risk, you easily can start with amoxicillin, TID, or the combination with clavulanic acid as TID or as BID. Or usually we prefer to start with 1 gram BID for 7 to 10 days according to the case and according to our patient. What about if there is no penicillin allergy but there is a pneumococcal risk? So directly shift yourself to the high dose amoxicillin clavulanic acid with extended release property. So what about patient with penicillin allergy? This is a difficult case. Really, this is a difficult case for us. I will tell my experience and our colleague will tell their experience. So doxycycline, I didn't use it for myself and I didn't see any of our colleague, at least in my practice, using doxycycline alone. So some of them will combine 3rd generation cephalosporin with doxycycline, and this is the recommendation. But most of them, they will not start both medication. They will go directly to fluoroquinolones. So the addition of clindamycin to cephalosporin provide improved coverage for beta-lactam resistant Staphylococcus pneumonia, although this carries an increased risk of adverse effect. What about macrolide? Are we still using macrolide for acute sinusitis? Are we still using macrolide? Some of us, I saw some patients still they having or they prescribe macrolide like clarithromycin and azithromycin. Unfortunately, the success rate with both medication is very low in our community. So what about the duration? For how long should we treat? So most of the time, we see prescription for 10 days, for 14 days. Should we go with this longer duration or shorter duration? So the latest recommendation is to go with a shorter duration, 3 to 7 days. They found it comparable to a longer duration, 6 to 10 days. But again, this is according to your clinical judgment and according to the status of the patient. 2 weeks back, I had a patient with severe pain with fever, and after the patient was examined by our colleague in ANT, they discovered that he has severe abscess, so they extend his treatment to 10 days and sometimes more than that. What about failure of initiation therapy? You started your patient on augmentin or amoxicillin combination with clavulanic acid for 7 days or for 10 days. The patient came back to you, doctor, I still having the fever, I still have the pain. What you will do? So failure of initiation of treatment, first of all, you need to confirm the diagnosis of acute bacterial sinusitis by history examination. If you are still having any query about the case, please don't hesitate to refer to our colleague in ANT. Maybe you will consider doing CT scan for paranasal sinus, maybe, but again, it's your clinical judgment. So for non-penicillin allergic patient who fail with the initial management, you can go with the extended release or with levo or with moxifloxacillin, okay, for a little bit longer duration, 7 days, more or less, depending on your clinical judgment. For penicillin allergic patient, again, levo and moxifloxacillin, of course, you need to know and you need to consider the side effect and long-term complications. Doxycycline, I don't have an experience with doxycycline in dealing with or treating sinusitis. What about second failure? So you treat 7 days, you failed, you treat for another 10 days, you failed. What should you do as a family physician? So patient who fail a second treatment course should have an imaging using CT scan. Okay, please consider referral. This patient may need a sinus culture or he may need some surgery for structural disorder abnormality. So we are still talking about definitions. What about relapse? What do we mean by relapse and when to say the patient is relapsing and how to act. So relapse means that there is a recurrence of symptoms within 2 weeks. Within 2 weeks. So the patient initially he improved, and after that he had the same symptoms again. So we call this relapse. If the symptoms is mild, so we can start the same antibiotic which the patient responds to for a longer duration. If the patient having severe, moderate to severe symptoms, okay, please consider imaging and referral and changing the class of the antibiotic. So imaging, what should we do or what should we order and when? Anybody using X-ray for sinus or sinusitis? Please raise your hand. No? So nobody is using. MRI, I didn't write it in my life. CT scan, of course, we agree about CT scan. So the recommended imaging for sinusitis is CT scan. Sometimes you will find a call from insurance, doctor, why you didn't start with X-ray? So they are forcing you, and this doesn't have anything to go or to deal with recommendation. Okay, please start with X-ray and then after that go to CT scan. Please don't do that. The only recommended imaging for CT scan for sinusitis is CT scan. So when to order in severe complication, relapse, or failure of second treatment, or not sure about the diagnosis. These are the four, okay, the four types or the four reasons why you need, okay, to order CT scan. So the question for you, is systemic glucocorticoids indicated in patient with acute bacterial sinusitis or not? What do you think? Did we see some prescription? Yes, we saw some prescription, prednisolone for acute rhinosinusitis. So the recommendation is it's not recommended. It is not recommended. So when given in addition to antibiotic, it may shorten the symptoms duration, risk for side effect is more, and antibiotic are enough to deal with acute sinusitis. So take-home message, acute rhinosinusitis is very common in our clinic, in primary health care and family medicine. Avoid over-diagnosing of acute bacterial rhinosinusitis. Avoid over-ordering for CT scan for the sinusitis. Be careful for complications, symptoms, and signs. Start antibiotic wisely to avoid side effect and resistance. Acute rhinosinusitis and migraine headache are the most common missed differential diagnoses. And finally, recurrent infections need investigations and referral. Thank you.
Thank you so much, Dr. Badr, for these illustrative presentations highlighting the proper approach to patients with upper respiratory tract infections and the use of antibiotics. So now we'll move to the second part, which is another interesting part about the spotlight on community-acquired respiratory tract infections and antimicrobial resistant. This is will be highlighted by our guest speaker, Dr. Wael Abdelkafi. He's a consultant otolaryngology and head and neck surgery in my clinic here in Jeddah. So we would like to welcome you here, Dr. Wael, and thank you for accepting our invitation, being part of this scientific session. Thank you.
Good evening. Thank you so much for the invitation, and thanks to GSK for the sponsoring this nice and great event. And thanks to Dr. Baird for the very nice presentation. It looks like he's not just a family medicine consultant, he's an ENT expert as well. So he will make my job easy. In my presentation, I will look at the problem in a different way. So I will try to be as applied as possible. Just to highlight what problems do we face daily in our practice. Upper respiratory tract infection patients, this is our everyday patients. If you have a clinic that has 20 to 30 patients, I think more than 75% of them will be just different types of upper respiratory tract infection. So let's see what we face every day, what are the problems, the problems in the diagnosis, how to look at those patients in a different way. So those are my disclosures. I will be highlighting some of the important subjects here, the definitions, which are well covered by Dr. Badr, symptomatology, and the very important part, which is the types. Are we dealing with viral or bacterial? Management and guidelines, and some clinical scenarios that we see in our patients, in our clinics daily. So the definitions are just an inflammation of the upper respiratory tract, and we can reach the bronchus, the trachea and the bronchus as well. You can see pharyngitis, tonsillitis, as Dr. Badr said, otitis media, rhinosinusitis, tracheitis, bronchitis, as it affects the different parts of the respiratory tract. And the symptoms vary about the site of the inflammation or the progress of the inflammation. Does it take only the throat, the sinuses, the nose, the nasal cavity, the trachea, the larynx, the epiglottis, according to the offending organism and the progress of the disease, and whether do we have any complications or not. And of course, we can expect some general symptoms as fatigue, malaise, body aches, headache, fever, things like that. So, in my opinion, the most important question when dealing with those patients, are we dealing with viral or bacterial infections? And we have a third category, which is secondary bacterial infection. So it's not only black and white. Sometimes we see patients, and in my opinion, this is very common category, which is the secondary bacterial infection. Secondary bacterial infection, we're talking about those patients who start with viral infection and with the immunity that gets a little bit compromised with the viral infection, we can have a concomitant bacterial infection. And sometimes at the end of the viral infection, we can get complications with secondary bacterial infection manifesting itself with bacterial sinusitis, bronchitis, pneumonia, and so on, and sometimes otitis media as well. So just pay attention about this progression, or sometimes it happens concomitantly together. We can get viral and bacterial infection together. And this is very common when we're dealing with influenza A and B. Those are the most common viruses that can affect the immunity and leads to secondary bacterial infection. In my clinic, I saw many patients with chronic throat infection. Chronic throat pain. Some of them, they are having this throat pain for about 6 to 8 months. And they receive different courses of antibiotics from different physicians. I have severe throat pain, and the initial diagnosis, well, that's an infection. It's been a long time. Looks like it's a bacterial infection. Just take antibiotics. And the diagnosis is usually an acid reflux. And the simple question of asking your patient, do you have acid reflux or heartburn, doesn't usually solve the issue, because most of those patients they have what's called the silent reflux, the atypical reflux, the laryngopharyngeal reflux, when you have only symptoms in the upper airway. Instead of asking the patient about, do you have heartburn, do you have acidity, ask the patient, do you have throat clearing all the time? Do you have mucoid discharge early in the morning that sometimes it's colored and the rest of the day it's just white? Do you have what's called global sensation, like sense of the lump in the throat? Do you have choking when you talk, when you eat, at sleep? Those are the most common symptoms of the atypical reflux or the laryngopharyngeal reflux. But rarely you will find heartburn or epigastric discomfort, the classic signs of the classic symptoms of the acidity. And this is, in my opinion, one of the commonest reasons for chronic throat pain. And when you examine the throat, you will find nothing. Sometimes just mucoid discharge in the posterior pharyngeal wall, and that's it. And if you have some swollen tonsils, swollen lymph nodes, sometimes tender enlarged liver or spleen, consider the Epstein-Barr virus or the infectious mononucleosis. That's sometimes with the cytomegalovirus as well. Again, we're going to talk about the secondary bacterial infection. Usually comes with the influenza viruses. Streptococcus pneumonia is the most common bacteria found in viral infections, complicated secondary with the bacterial infection. And this is usually associated with high morbidity for the patients as well. And Streptococcus pneumonia and Haemophilus influenza are the most common reported bacteria associated with secondary infections during the flu seasons as well. Many studies have shown that influenza infection will, not just the common cold, we're not talking about the rhinoviruses and so on, but the flu viruses, the influenza viruses, the one that we have vaccines for, they facilitate the acquisition, colonization, and development of diseases from Streptococcus pneumonia in people of all ages. Just pay attention of this progression or this concomitant relationship that you can get viral and bacterial together as well. One of the important parts of the examining the patient, if you can get ear pain at the beginning of the flu symptoms, that's usually viral. So patients with the sudden onset of throat pain, sneezing, itching, coughing, and concomitantly at the same time he developed ear pain or pressure, that's usually viral. Even if you examine the ear and you find congested eardrum, that still it's viral. But the ear pain and congestion of the eardrum that happens after the end of the symptoms, that's usually bacteria, that comes later. And the typical scenario that the patient comes to the clinic saying that I had the flu, runny nose, throat pain, and 2 days ago I was perfectly fine. And then I developed this severe ear pain, that's usually bacterial. As Dr. Badr said, the duration is very important. The symptoms for 10 to even 14 days of just viral infection without clear signs during the examination of a bacterial infection, that's usually viral. But after that, if the complications, the complaints of the patients are getting worse, the green, sticky, yellowish discharge coming usually post-nasal, and the headache upon lying down with sujood or ruku' and so on, usually consider the bacterial infection as a cause for this progression of the symptoms. So the common viral infections that we see every day, we are dealing with common cold, influenza, and Epstein-Barr virus. And this is commonly overlooked in our practice. The common cold, we're talking about rhinovirus, adenovirus, parainfluenza viruses, respiratory syncytial virus. These are mild to moderate symptoms, usually without high fever. Symptomatic treatment, we don't have vaccines for those viruses. And the other type, which is usually during the flu season, we're talking about the influenza viruses, the most commonly or the most dangerously, the A and B. And it's divided into different subtypes based on the combination of two proteins on the viral surface, namely the H and N. That's why we have H1N1, H5N1, and so on. Those are just different types of the influenza viruses. And the swine flu and the aviation flu, those are just variants of the influenza viruses. So the exact diagnosis by the nasal swab, but usually we don't wait for the swab test. If you get a patient with a viral infection with high fever, 39, 40 even, and without the classic signs of a bacterial infection, consider influenza A and B, and you can start antiviral treatment without waiting, unless you have the rapid test in the clinic that comes within few minutes, and you can write antiviral accordingly. But sometimes the PCR takes like 10 days to get the results, so we cannot leave the patient with just symptomatic treatment. You need antiviral for those patients. Pointer. طيب, some of the problems that we face in the clinic, that we can get a picture of a bacterial tonsillitis, typical bacterial tonsillitis, and that's just an Epstein-Barr virus or infectious mononucleosis. It gives a picture exactly the same, and you have tender lymph nodes, you have fever, and so on, and you start antibiotics without any response. So please consider the possibility of the EB virus, because the clinical picture is exactly the same. And the common bacterial infections that we face as a complication, which is the rhinosinusitis, covered perfectly with Dr. Badr, the otitis media, tonsillitis, pharyngitis. I will just skip. Usually with the endoscope, we can see in the clinic, nasal scope, we can see those sure signs. That's pus, pure pus coming from the middle meatus, or trickling down to the posterior choana or the postnasal space. And those are the common bacteria isolated from the rhinosinusitis patients. The Streptococcus pneumonia and the Haemophilus influenza are most common. And the susceptibility, and those are different studies with almost the same results, that we have the different antibiotics. And it's very important, as Dr. Badr said, that you should have different antibiotics or different choices, because sometimes your patient is allergic to this antibiotic. Sometimes he's taking another medication that is, you can get a drug-drug interaction between your antibiotic and his medications, and so on. So you should have options, always have options for different types. When we talk about the acute otitis media, it's an inflammation in the middle ear cleft. Middle ear cleft, we're talking about the middle ear proper, the Eustachian tube or the Eustachian tube, and the mastoid air cells. So all of these areas are considered middle ear infection. It takes all these parts. When you examine the patient, sometimes you don't see any landmarks, just congested eardrum like you see here, with severe pain, of course, and hearing loss. And those are the commonly isolated bacteria. When you're just tapping the eardrum and we don't usually do that, but sometimes the patient comes a bit late, or the organism is very virulent, that the progression of the symptoms for just ear pain and the stage of the perforation overnight, and he comes the second day with pus trickling outside the ear. One of the important parts in the examination, the bullous myringitis. This is a viral infection. It comes with severe pain, usually with the influenza infection, and you can get Ebola like this, just swelling, and it's really painful. And this is one of the cases that you need steroids for that, systemic and topical steroids, because antibiotic has no rule, it's just a viral infection. One of the important issues, the sequelae of the otitis media patients, whether viral or bacterial or even barotrauma, that we can get, you can subside all the symptoms for the patients of the ear pain, blockage, but he's still complaining about ear pressure or ear blockage, and this is what's called middle ear effusion. So this is the normal eardrum, translucent membrane like the first picture, like here. And the effusion, you can get the eardrum retracted inwards. You can see air bubbles as well. And we have different types of effusion. You can get this mucoid effusion at the end or serous effusion. So what happens if we leave those patients who, that complaining of hearing loss that, well, everything's going to be fine, it will take a few weeks and you will be fine and so on. Sometimes we reach this end stage, the atelectasis. The eardrum is severely retracted inwards and become attached to the ossicles and the promontory and so on. So in the stage number 2, the effusion, we can put grommet tubes and so on and get relief of the patient problems easily. But when we see the problem with the atelectasis, even the surgical treatment, it's not that successful. So it's very important to catch those patients in the middle group. One of the misleading problems that we see every day, again, the middle ear barotrauma. The usual scenario, a patient coming from a vacation or coming from a flight, and during the flight, he caught a flu. So he had the flu 1 or 2 days before the flight. And during landing, he cannot equalize the pressure in his ears. He tried to swallow, to chew some gum, or to do the Valsalva maneuver. Some of the patients know how to do the Valsalva maneuver, and all of this didn't work. And when he landed completely, he runs to the hospital. When you see the ear, you can get congested eardrum, but he feels pressure more than pain. And the pathogenesis of the problem that the negative pressure behind the ear can cause hemotympanum or blood inside the middle ear. So this is just middle ear barotrauma. It's not an otitis media. It's just failure to equalize the pressure during landing. Or even patients who are living in Taif, for example, coming down from a Taif exactly like the same, like landing from a plane. It's usually the same. So simple management with myringotomy and grommet tube can protect the eardrum, can equalize the pressure, and relieve the patient's symptoms. Pharyngitis, tonsillitis, adenoiditis. It's an inflammation of the tonsils and adenoids. And some of the submucosal lymphoid tissue as well. Sometimes we see lingual, when you just examine the throat, you find the palatine tonsils normal and the inflammation in the lingual tonsils. Again, this is how the bacterial tonsillitis and the infectious mononucleosis, how it looks really similar or it looks the same by examination. One of the problems that we see when you examine the throat and you find these tonsillar stones. Some of the patients, as a difference in the anatomy of the tonsils, they have very deep crypts. The crypts that usually on the surface of the tonsils, some of the patients have deep ones, and they accumulate the food and debris and some of the normal throat mucoid discharge, and they form the stones. And those stones can be really irritant to the patient. And for the first look, you can see that this is an abscess, or this is an infection, or follicular tonsillitis, or bacterial tonsillitis. Well, it's just stone and needs to be removed in the clinic, or sometimes if it is recurrent, we need to remove the whole tonsil for that, because it can cause some the halitosis and the bad odor. It's one of the common causes. And sometimes just simple pharyngitis and tonsillitis with a virulent organism can progress to peritonsillar abscess. Usually you will find one tonsil pushed medially and the uvula is not central anymore. So you can suspect the presence of a peritonsillar abscess. And put in consideration when you're dealing with patients with throat pain that we have viral pharyngitis with congested palate and congested tonsils, and it's just viral. It's been estimated that usually the viral infection, pharyngitis, it's 70% viral. So usually patients with coming after 2 to 3 days with throat pain, that's just viral. We don't need antibiotics for most of our patients. And the throat pain can be either, like Dr. Bed said, can be fungal, especially for those patients who are taking inhalers and they are not doing a lot of mouthwash or gurgles after using their inhalers for their asthma. And they are very susceptible to fungal pharyngitis, and you can find these fungal spots like that. Sometimes the patient is complaining for pain because of his having an aphthous ulcer without any signs of upper respiratory infection or viral infection or whatever. Just an aphthous, a big aphthous ulcer in the throat, in the tonsil, in the palate can cause severe pain. And sometimes you just need to give hyaluronic acid gel. Sometimes you need steroid for big ulcers. And well, we don't see that a lot. Maybe our colleagues in the pediatric department or our colleagues pediatrician, they see this much more common. The hand, foot, and mouth disease, the Coxsackie virus. And as Dr. Badr highlighted, we need to pay attention for the complicated cases. Again, this is an orbital complications. If you get an acute otitis media complicated by swelling of the ear, or the ear is pushed laterally or changes position, we can get what's called coalescent mastoiditis after acute infection of the mastoid ear cells. I think this is a very important point and worth mentioning. It's been estimated that about 30 to 40% of the normal population, they can have dehiscence of the facial nerve inside the middle ear. And this is not a disease, it's just an anatomical variation. So the facial nerve, usually it's covered with bone. It has a course inside the middle ear and then the mastoid. But 30 to 40% of the normal population, part of the facial nerve is dehiscent. It's not covered by bone. So imagine that one of those patients, they develop acute otitis media with the facial nerve is exposed like that. He will immediately get a facial paralysis, whether pediatrics or adult. Child or adult. So acute otitis media complicated by facial paralysis, that's usually the cause. And again, those patients need a myringotomy to relieve the pressure immediately, and those one of the cases that needs antibiotics with steroids. About the antibiotic guidelines. So the guidelines are not just to push you to use a certain antibiotic. It's just to give you a roadmap. In this type of infection, you have those options, option 1, 2, 3, 4, and you need to deal with your patients accordingly. Again, you need to know all the medical history of the patients. Some of our patients, they don't tell you about the other medications that they receive. They don't think it's important, even if, especially if they are taking some psychiatric medications, and you need to stress upon that. Some of our cardiac patients, you cannot give macrolides, or sometimes it's dangerous to give them quinolones for the cardiac patients. They interact with the cardiac condition and so on. So it's very important to know the medical history. Are they taking any other medications or not? I thought this worth mentioning. And before presenting this, do you give vitamin C to your upper respiratory tract patients? It's common practice, and most of our patients, they come to the clinic asking for vitamin C as the treatment, and it's only a psychological treatment. So it's not really effective. And the literature review of the real value of the vitamin C, it's a Cochrane review that vitamin C as daily prophylaxis at a dose of 0.2 grams, it has a very, very mild effect on the course and the severity of the symptoms, whether in the pediatrics or adults. So it's 8 to 13% decrease in the duration for adults and children. 8 to 13. I don't know even how they calculated this 8 to 13%. But to give, when you start the symptoms of flu, just giving high doses of vitamin C, it's not really effective. So I try to tell my patients that, but sometimes they insist of prescribing vitamin C and just give them vitamin C, and that's it. But I don't think it's effective. It depends on your healthy lifestyle before getting the infection. Do you eat vegetables or vitamin C containing vegetables and so on, or fruits? So let's talk a bit on our situation here. We can get access to different guidelines in the US, in Europe, and in different countries. But it's really important when talking about the antibiotic resistance, the antibiotic guidelines, the antimicrobial resistance, to have our own data here. So that's really important about our practice, what's happening in the kingdom. So let's agree that antimicrobial resistance, it's a real problem. Let's imagine that in 10 or 20 years, most of the antibiotics nowadays in use, that they are not working. And there is failure of your medications. So what will be our situations? And we're not getting new antibiotics in the market as quick as how we lose them. We are losing many antibiotics that's been using before, they are not in use right now. But we're not getting new antibiotics that fast or that frequent. So let's start with what's going on outside. It started with the World Health Assembly formulated the Global Acting Plan for Antimicrobial Resistance in 2015. And in response, there is a National Action Plan on the antimicrobial resistance, and this was published in 2017. And that's the paper right there. But some of the studies done here in the kingdom wasn't really in the favor of the practitioners. It wasn't really in our favor, because the studies performed here that it's all about the misuse of the antibiotics among the practitioners and the doctors. And a large 2016 multi-area study here in the kingdom, the sample was 1,700, showed that 76.8% of respondents had recently used antibiotics, 71.7% taking antibiotics for colds. And sometimes it's a pressure from the patient. And our patients usually correlate the severity of the symptoms with the need of the antibiotic. If I'm having severe symptoms, fever, body aches, then I need antibiotic. Well, it's our role to try to educate our patients that it's not related. The COVID virus, it's a virus. Antibiotic has nothing to do with the viruses. And the study in Riyadh as well showed that most participants were aware of the potential adverse effects of antibiotics, but nearly 40% had taken non-prescription antibiotics in the previous 6 months, mostly for just flu. As it's correlated, if I'm having severe symptoms, I should take antibiotics. Still, we have very strict laws here in the kingdom right now that you cannot give antibiotic over the counter. But it's really happening. In the real world, it's really happening. It's still happening right now. And our colleagues in dental, they always write antibiotics. Whenever any dental procedure is being going, they usually give antibiotics for that, which is not always necessarily. I will review some of the important points here in those slides. Those are the important studies done to just analyze the susceptibility of the different antibiotics to Streptococcus pneumonia. And you can see that we can get the quinolones nearly 100%, amoxicillin clavulanic acid like almost 9%, and so on. Macrolides are not that effective. Dr. Badr mentioned that in his slides. But again, when prescribing different antibiotics, you need to be aware about the potential complications, the drug-drug interaction between the patient medications, his other problems as well. Again, for the Haemophilus influenza as well, the amoxicillin clavulanic acid are nearly 100%. So it's important to choose the safe medication. So those are our data here in the kingdom, that 88.9% of Streptococcus pneumonia were susceptible to amoxicillin and amoxicillin clavulanic acid, but this fell to 52.8% for macrolides, erythromycin, azithromycin, and clarithromycin as well. For the fluoroquinolones, it's 100%, but still you need to judge the potential problems for those antibiotics. And for the Haemophilus influenza, the high susceptibility, again, for the amoxicillin clavulanic acid, cefpodoxime, and ceftriaxone. So those are the common guidelines that we use them as a reference of our practice. So those are very important points, just need to be mentioned that we are still in the era of antibiotic overuse and misuse. Prescribing antibiotics for bacterial infection is challenging and requires detailed infection antibiotic knowledge. Here in the kingdom, we need to establish still our local or our own guidelines with the repeated studies. And this has been actually going right now, but we need to always stick on our local guidelines instead of the international guidelines. And that's it for now for the presentation, and thank you so much.
Thank you so much, Dr. Wild. And now I would like to invite both speakers to be on the stage here so we can receive the questions. We'll open the floor now for the attendees. Any questions here? Dr. Muhammad.
Thank you very much. I think it's for antibiotic overuse or abuse, which is a very important subject. First, let me attack Dr. Badr regarding, if I don't have, I'm somewhere in the rural area, why shall I omit the X-ray and then to go CT? CT is not available everywhere. While the old classic, when we do it, then we can see in the sinuses the level. This is why, what's the new view regarding? My second question regarding those infection going through the sinus, otitis media, all through going inside there. I don't, deep inside, even if we go a little bit to the pituitary fossa, where it's very hard, not the antibiotic to be not enough to attack, but it is very hard to reach there. My question, is there a way for hyperbaric therapy to be used? Thank you.
Okay, thank you, Doctor. So maybe the second question I would refer it to our colleague because it's mostly related to ENT. So the first one, usually we order CT scan. The comparison between CT scan, even from our practice of primary care, and we will hear that the ENT, of course, opinion, the X-ray will not show the depth of all the tissue and the same accuracy with the same sensitivity and same specificity, number one. Number one is not informative regarding the other soft tissue. We are maybe the problem, the deviated nasal symptom, the turbinate, okay. And sometimes even if the patient is having sinus infection, it's not always appearing in X-ray. So the sensitivity and specificity of X-ray comparing to CT scan is very, very low, and it's just a waste. That's why even in the guideline to diagnose the patient with sinusitis and to start treatment, it's not mandatory to order CT scan. Very certain criteria, okay, to start or to do CT scan. Even if you are traveling, okay, no need to do CT scan unless, okay, there is failure or relapse or there is a query about any complication from the sinusitis. The second question about, spreading to the other places, I will refer this to you, Doctor.
Thanks for the question. I will just comment on the same subject again. It's been estimated that the X-ray paranasal sinuses, the sensitivity to diagnose sinus problems, in best hands, it's not more than 40%. The maximum is 40% sensitivity to diagnose because of the overlapping bones behind each other. And we need to know whether it's a mucosal thickening, it's air fluid level, and do we have bone erosion? Are we impending complications? So we don't get those information from the X-ray. So that's why it's almost obsolete because of the sensitivity to diagnose what we need to know. Regarding the question of the hyperbaric oxygen therapy, it's definitely one of the methods that we use, but it's not available everywhere. And it's not easy to refer the patients to get hyperbaric oxygen therapy, and we still have the problem with the insurance to approve this part of the, or this type of management. But instead, getting CT paranasal sinus and see if sometimes we have a patient with chronic headache. And when you examine the patient, everything looks perfectly fine. With CT scan, it's an isolated sphenoid sinusitis. And usually the organism is just one of the staph species. And that needs surgical intervention. It's just an isolated infection of the sphenoid sinus. That's it. Frontal, ethmoid, maxillary, all is perfectly fine, just sphenoid sinusitis. So again, the CT is really important to diagnose exactly what you have. But that doesn't mean that you need it in every patient with sinus problems. Just give treatment and follow up. If the symptoms went away, that's expected. Sometimes ordering too much CT scan will confuse you and the patient because you will get the diagnosis report as mucosal thickening for clinical correlation. Well, this mucosal thickening would have vanished if you just leave the patient for 2 more months, like the chest X-ray. If you got pneumonia or chest infection, and the patient's clinically improving, but in chest X-ray, you will find that they're the same. After 1 week, after 2 weeks, it will be probably the same, but the patient's improving. So when to ask for the investigations, and is it really valuable in every patient with sinus infection? I don't think so. So I think it should be CT scan, but well organized regarding the timing.
Okay. All right, thank you.
For that, I mean, if somebody in the desert, away from all the, not in Jeddah or a big city, this is why to start with just initial with the X-ray. Second, the high dose, it's burning. I mean, when we do a CT, so this is why it's burning all the tissue. That is my question, Mara.
Right.
Thank you.
Thank you so much. Dr. Wael, Dr. Badr, you know that we are confronting with a lot of challenges during certain season, especially Hajj season and others before and after. And we come across cases where we have RSV virus, we have EB virus, we have influenza, we have COVID, and we have others. Shall we take a swab for each suspected case, or we just go symptomatic treatment and we wait for the complication and then the conversion of the viral to bacteria, and then we start antibiotics? So what is the approach?
So before COVID and after COVID.
Still we have cases.
Yes, yes. Nowadays, we are not taking swab unless, rarely for certain patient, for certain purpose, okay, especially for healthcare workers, mostly, okay. But most of the patient, okay, we will observe, we will follow up, we will treat the patient, okay, with all the precautions, okay. We'll give the patient sometimes like a rest for 1 or 2 days, and after that we will follow the patient. So I believe that taking swab just to confirm is it influenza, flu A or B, unless there is like guidance or direction from the infection control that they need like a certain statistic or something like that. For certain people who insist, some patients they insist, I want to know exactly what's happening. Viral is viral, okay? Yes. Unless there is a restriction from certain areas like airline or others, they're requesting, okay, certain investigation, we will do it. Okay, we are doing that. We are doing that sometimes, okay? Maybe just to know exactly what the diagnosis. Sometimes maybe if the patient come in the follow-up and still we don't have the diagnosis, Sometimes we will order that, okay, but still it's not commonly used like before, like in COVID.
Thank you so much. We have a question from Dr. Mohammed Al Khair. I think he's attending with us virtually. I think this is a question for you, Dr. Wael. Do you think that the nasal wash helping in treating rhinosinusitis? And what about using nasal spray, which is flucazone and budesonide in the treatment of rhinosinusitis?
Okay, that's a very good question. The local care and the local management in sinus infection is really important with some precautions. When we do nasal wash, we are just cleaning the nose. When we use steroid nasal spray, that's a topical anti-inflammatory medication, which is recommended in sinus infection. But there is a very important point here. Are we going to use the nasal wash as a spray or as a pump that gets the fluid from here and coming from the other side, which is very risky when using those pumps. I don't recommend using those pumps for my patients. Usually, when you do some pressure on the pump to get it cleans better, but it gets the infection in the middle ear. Usually patients, when they do the pump, they are very motivated to clean the nose and the sinuses in a very, very nice way, and they get the fluid from here to here. But during this way, they are getting fluid with the infection through the ventilation tubes inside the middle ear. And we can end up with middle ear infection on top of the sinus infection. So I totally agree about using the local care, and we prescribe them commonly, but use the spray, not the pump.
Okay, thank you. How about the overuse of xylometazoline, rhinitis medicamentosa, which is commonly prescribed in primary care?
Yes.
And we get the complication of people coming
Exactly.
to us, and it's almost like addiction.
Yes, exactly. It's an addiction.
Yeah.
When you are using xylometazoline or the nasal congestant drops or sprays, they decongest the turbinates so you can get a perfect airway. But when you lose the effect of those medications, the turbinates don't come back to its normal side. It comes back in a bigger part, in a more larger size. So you need, instead of using it at bedtime, you need to use it 2 or 3 times a day. And after that, you will find some of the patients, they are having the spray in their pocket. They cannot walk without it.
Absolutely.
And when we reach this, we try to withdraw the xylometazoline with the use of saline nasal spray, but the hypertonic saline nasal spray, because the decongestant effect for the hypertonic is better than the isotonic.
So what is the proposed duration for using 5 days?
Maximum 5 days. That's the maximum, 5 days.
Okay.
You can use it, but max 5 days.
Okay. How about the ballooning for rhinitis?
I don't have that much experience. You mean for the turbinate?
The turbinates, yeah.
Ballooning to decongest.
Yes.
I've seen some patients with good results, but this is not one of the standards of the medical practice.
Okay.
It's not, it's not hazardous. You can use it and you can tell that you can get better or not, but it's not one of the standards of practice.
Do we hear? Okay.
Assalamu alaikum. I just have a question, like from your practice, when you have patient insisting for antibiotics with the busy clinic, do you end up, we know the guidelines, we know mostly it's viral, but do you end up, Dr. Badr and also yourself, please, for both of you, and also Dr. Ashraf, what's your approach? Do you just give it? Or do you still have, what's your tips or tricks of the trade for that?
Yes. As you said, we know the guidelines, but in the real world, that's not really happening. When you have a patient insisting on having an antibiotic and he will not leave the clinic without the antibiotic. When you reach the situation with this kind of patients, I write the antibiotic and tell the patient, please wait for 3 to 5 days without using it. Because in my opinion, you will get better without the antibiotic. That's what I do.
Okay, the same, Ahmed, Dr. Ahmed, I believe this is depend mainly on the trust of the patient, number one, the doctor-patient relationship, number two, and what is the time you spend with your patient, okay, clarifying, number one, discussing, okay, advantages and disadvantages of taking this. I believe from practice, 95% more or less of the patient will be convinced, okay? Fewer patients still will insist, simply I will do it the same, okay, with very close follow-up with our patient. It's difficult, but I can see like the practice 10 years back, okay, compared to now, much, much better than before. So only less than 5% will insist. I believe we can deal with it with good doctor-patient relationship, explaining, clarifying, and that's it.
You're waiting for my answer. Well, it's a really surprising when we discover a patient who is newly diagnosed to be a patient with diabetes or hypertension or dyslipidemia. Patients are resistant to take the medications. But if there is an upper respiratory tract infection, they are volunteering to and forcing you to prescribe them the antibiotics. So there is some kind of controversies. But I think it all comes about how we establish a good doctor-patient relationship based on the trust and professionalism. But again, I will not do it at all. I will try to spend a little bit of time just to convince the patient and to educate the patient between the difference between viral and bacterial infections. And if he insists, I will apologize and I will ask him to stay on my recommendation for a couple of days, and if it doesn't improve, he should come back to me again. Because here you have to secure two interests. One, the interest of the patient as an individual, and the interest of the community for microbial resistance. So this is your responsibility, and you have to be accountable for it. So this is the way, and I think this was one of the difficult consultation in the board of family medicine, how to convince patients with demanding for antibiotics. Thank you so much. I think, Chris, you have a question over there. Mike, please.
Good evening. My question is, what is our role or should be our role as a nurse or healthcare provider in controlling infection and in controlling the microbial resistance for our patients, antibiotic resistance?
Good question.
Thank you.
So what is the role of nurses in controlling the infection in outpatient departments?
Yeah. So after COVID, so following the infection control precautions and policy. So this is the I believe the next slides, okay, for the great presentation that we heard today about, the Saudi national policies and guidelines. So I believe in each hospital, in each center, there is an infection control. And we need to hear from them, and we need to have multiple meeting with them just to know the policies, the precautions, okay, number one. Secondly, we need to know the statistic about all the antibiotic resistance, okay? So they should come to us, okay, Dr. Badr, you shouldn't prescribe this. We found that macrolide in the kingdom or in the Gulf region, it has almost 40 or 45% resistant. So I should change my practice. I should change my beliefs, okay? So I believe a good communication and periodic meeting with infection control, okay, in each center is very important for physician and nurses. Secondly, always I'm bothering Christina, I'm saying to her, please ask the patient, even if the patient is coming just to refill his diabetes medication, please ask, do you have cough, especially in season, winter season? Do you have cough? Do you have fever? Do you have sneezing? Many times we discover that the patient is having pharyngitis or the patient is coughing, okay, and he didn't tell the nurses and he didn't tell us. So I believe giving the patient from the beginning the mask before coming or entering to the physician and even start staying and sitting in the waiting area, this is very important. Having all the sanitizer, washing the hand, educating the patient how to wash the hand, even in your clinic, I believe this is very important. So infection control, it is our responsibility as physicians, as nurses, even the housekeeper, everyone working in healthcare worker centers, they should be aware about the infection control policy.
Thank you so much. So because of the sake of the time, I have only one question. How long you will just maintain the antibiotic course if the patient did not respond? When you switch to the second antibiotics, do you go for the full course, or you just depends on the symptomatology of the patients and the improvement or the progression of the problem?
Okay, the first question, when do you decide to change?
Yes.
I give it 3 to 5 days maximum. If we're not getting any improvement in the symptoms, we should change. We don't complete it for more than that. And with the change, I monitor the patient after 3 days only. So just 3 to 5 days without any clinical improvement, and you have clear signs of bacterial infection, you should change the antibiotic or ask for culture sensitivity. But usually I change the antibiotic before shifting to a culture sensitivity. And after 2 more days or 3 more days maximum, you need to get the patient again and see what's going on.
Another 5 days.
Excuse me?
Another 5 days.
After shifting to the antibiotic, I wait for only 3 days. 3 days and get the patient back. See if he's getting better or not.
So should we do nasal swab?
The problem with the nasal swab that to get the nasal swab that is not contaminated with the other normal flora in the nose, it's extremely difficult. It's extremely difficult. So the clinical judgment is much better. I don't really believe in nasal swabs getting inside. You need to get it from the middle meatus, and it will become contaminated with many bacteria on your way to the middle meatus.
Okay, ladies and gentlemen, dear colleague, I would like to thank you for your attendance today, because this was the last questions delivered to our speakers. And I would like just to remind you, all of you, as a primary care physician, that we encounter upper respiratory tract infections, and it's almost like a bread and butter of our day-to-day practice. Remember that there is antibiotics that can be used with a double sword edge, so we can use it for the benefit of our patient, but we can abuse it and we get into the microbial resistance. So please use the appropriate antibiotics as it's recommended through this duration which is recommended, and then to the appropriate case which is required. So with this, I would like, on your behalf, I would like to thank our guest speakers, Dr. Wael, Dr. Badr, for the wonderful contributions, for enriching our scientific event with a lot of information, a lot of clinical insights, and a real practice, expertise. Thank you for all of you. Thank you for GSK, and thanks for the Saudi Society for Family Medicine that brought us, all of us, together. Stay tuned for the 39th session, scientific session. Inshallah, it will be next month onward. We are going to get you together to highlight these kind of clinical dilemmas, a clinical challenge. Thank you so much. Wish to see you again. Ya Amanillah.
Thank you so much.
Dinner will be in the ground floor, okay? So please get your dinner in the down floors. Thank you.